I chaired today's BMJ Masterclass on care of the older person. We had some really stimulating talks from experts and lots of good discussion afterwards, which I think was challenging for participants, but very good information and knowledge to take back to their practices. What I took back is that it's really important to watch a patient walk, whether it's when I'm assessing them for falls, thinking about Parkinson's disease, thinking about somebody who's acutely ill, can they walk, are they mobile? And the importance of keeping people walking in a structured way when they have dementia to prevent wandering. So I will continue to go and fetch my patients from the waiting room, bring them into the consultation room before I start the formal consultation, because that observation is really important.
Okay, so my key message for the care of older people is to understand the complexity of the underlying disease processes. It's a combination of their physical, social and psychological well-being, and whatever we do, we have to get rid of outdated terms like acopia, off legs and social problem. There's no place, let's stop it.
My key message is to explain carefully to the patient the risks as well as the benefits so that they can make a choice to decide whether they want to continue drugs or not.
My key message for today is that if you have a depressed older patient, always think of the psychological as well as physical reasons for depression, and think about psychological treatments as well as physical treatments.
Frail elderly people are at high risk of falls. A targeted multidisciplinary risk assessment and polypharmacy reduction can not only reduce the risk of falling, but also injurious falls can be reduced as well.
Parkinson's disease is an area of increasing complexity. The key thing in primary care is to get the diagnosis right in the first place. 2 tips. In Parkinson's disease, the patient's motor symptoms should respond to levodopa. And the second thing is, look at their feet when they're walking. A patient with Parkinson's gait has a narrow base.
Caring for patients with dementia is core business for general practice. We're the part of the health service that has continuity of care still. We reach the entire population. General practitioners are great problem solvers, and rather than being protocol users, and are very good at systematising care. We need specialist help with the complicated, difficult diagnoses, with patients who've got red flag symptoms, and for the management of behavioural and psychological symptoms later in the disease.
I think the key messages I'm trying to get across is the really important role that GPs play in caring for their population of patients. About 1% of their population will die each year. Really crucial role that GPs can play in helping people live well till they die. It isn't just about dying, it's about living well till they die. And the 3 key things that we recommend within GSF, the GSF programs, are to identify people earlier and to use prognostic guidance to include them on a register, the 1% of the population, to assess their needs and their wishes, what's important to them, and thirdly to plan to give care the way they would like it, plan care in alignment with their preferences. So the three things we say within GSF: identify, assess, plan, but keep on with the good work that you're doing.